Thank you all for joining us. We're looking forward to a fantastic session with our speaker and hope you find it engaging and valuable. Without further ado, I would like to turn over to Dr. Morrison to introduce our speaker for tonight.
Hi, everyone. I'm Donna Morrison. I'm the Hudson Valley Governor for NYACP, and I am pleased to introduce Dr. Sahar Iqbal. She's an associate professor of internal medicine since 2017 and also cross-appointed to the Division of Population Health and Applied Health Sciences at MUN. She's a fellow of the Royal College of Physicians and Surgeons of Canada, a fellow of the American College of Physicians, and the ACP governor of the Atlantic provinces in Canada. Her clinical and research work focuses on diabetes, obesity, and metabolism, but she's also extensively involved in graduate and undergraduate medical education at her institution, and she's involved with both hospitalist and outpatient medicine. I have worked with her at National ACP, where her perspective as a Canadian physician has been very valuable as we discussed health policy issues that are now affecting the United States. And I spent like half an hour trying to think of tariff jokes to make, but I couldn't really come up with anything good. So if anyone has anything good, they can put it into the chat. And now I will turn this over to Dr. Iqbal.
Thank you so much. I'm so excited and so pleased and honored to be here. Thank you so much, Donna, for giving me this opportunity. And Dr. Morrison, Dr. Lanson, I'm happy to be here. Thank you so much, Loretta. So here's what we're going to talk about today. Comparative review of healthcare systems in the US and Canada. And just a little overview. We're going to have a slight introduction, and then I have no conflict of interest, but I do want to declare I am Canadian. And we're going to talk about the healthcare systems in the US and Canada, then a brief history of health policy development in the US and Canada. We'll look at a comparative analysis, then we'll conclude and hopefully have a lively Q&A session. If anyone has comments or questions, you can jump right in. Okay, just to start here, US and Canada occupy almost all of the North American continent. The US population at approximately 347 million is about 10 times the size of the Canadian population. And this is important to recognize when we look at some of the data later on. So here's what we're looking at for the US. You're looking at an area of 9.867 million square kilometer and a very large population. And we're not going to delve deeply into this, but just to look at Canada, we have 9.985 million square kilometer and a population of 40 million. So we have the same size of a country, but 1/10 of the population. So therein lies many of the differences that we're going to look at. Now, we do, despite all the differences, we have a very big and important shared goal, and I want to talk about that. We have shared history, language, culture, a democratic system of government, a capitalist system of economy, an 8,891 kilometer or 5,524 mile long border. And most importantly, the shared goal of providing healthcare to the respective populations of the US and Canada. Both healthcare systems are complex and were quite similar until the 1960s and the 1970s. For example, in 1971, the GDP spending was about 7.5% in both countries. After this, the systems evolved divergently into the current systems. So just going to talk a little bit more about the healthcare systems in US and Canada. This is not going to be an exhaustive discussion, just barely touching on some of the important points that will help us understand the differences later on. Okay, so the US system, one of the largest and most complex healthcare systems in the world. It is a multi-payer system with no universal healthcare coverage. Instead, it mixes public, and private for-profit and non-profit insurers and healthcare providers to provide health care to its population. So then the US government also funds various programs and subsidies for special populations. And I don't need to give you more details on this one, but Medicare, Medicaid, Affordable Care Act, most recently, are something that we would like to mention here. Just briefly here, federally funded agency that provides services to people 65 and older, some people under 65 with disabilities or conditions, as well as programs for children, government workers, low-income and unemployed people, and veterans. Medicaid is a joint federal and state program that covers medical costs for some people with limited income and may provide benefits such as nursing home care or personal care services if you qualify. Now, Medicare is a word we use also for the Canadian system, but it does mean something slightly different, and we'll get into that. And now, what does the Canadian system look like? Canada has a decentralized universal single-payer system, and sometimes people are not completely convinced that it's a single-payer system because we actually have the federal government, the provincial government, the territorial government, and various other iterations of how it is actually funded. So, but largely, it is a single-payer system. And it is actually called Medicare, the Canadian Medicare. So it is distinct from the American Medicare, but the name is exactly the same. And it is not a single system. It is actually 10 provincial, 3 territorial healthcare systems that are responsible for management, organization, and delivery of healthcare for their residents. And the costs are shared between the federal, provincial, territorial governments. Now, the federal government basically covers the provincial government or territorial government to some extent, and that has changed over time. Initially, when we started, it was 50-50. Now it's not like that. But there are 5 pillars of the Canadian Health Act, which was enacted in 1984, that must be fulfilled before any federal funds can be transferred to provincial or territorial government. And these are the following: public administration, comprehensiveness, universality, portability, and accessibility. So essentially, it is publicly administered. There's no private healthcare. It's comprehensive care. So all sorts of care that is required is provided. It's universal. It's for everyone. And portability essentially means if you go from one province to the other province or to a territory, it would still be covered. And accessibility, of course. So what's covered? These are the services that are insured: inpatient, outpatient hospital care, medically necessary care for maintaining health, disease prevention, diagnosis, and treatment of injuries, illnesses, or disabilities, and medically required physician services. Other things that the provinces or territories may cover are the following. So the ambulance services, the 911 service, children, geriatric, rehab services, prescription drug coverage, which is potentially different in every province. And then, of course, things like the chiropractic, dental, and vision care. Dental has become probably the most important thing that just got covered in the last few years. And then we're going to look at the brief history of health policy development in both countries. So first, a little bit about the timeline of the major US health policy accomplishment. And obviously, there was some system that was going on before all of this time frame, but we started to understand this a little bit better and the needs of the social structure that existed at the time and whatever was required at the time was enacted. And I don't want to go into the detail of each one of these policy accomplishment, but I do want to look at some of the highlights. So this is what I felt would be most important to understand. So then the first thing that I looked at was the Stabilization Act in 1942. This is the practice of the employer-sponsored health insurance. And this is where the roots of some of what is happening currently are based. In 1948, the American Medical Association launched a national campaign against national health insurance. So this is interesting, and I'm highlighting this because we have something similar happening in Canada as well, around that same time frame. In 1965, of course, the Medicare and Medicaid programs were enacted. Then we have the Health Maintenance Act in 1973. This encouraged the development of managed care, while advances in medical care revolutionized treatment. And then we have the Affordable Care Act in 2010, which extended healthcare coverage to millions of uninsured Americans. So these were some of the highlights. This is, again, the Canadian Health Services Policy Research Timeline. And once again, I don't want to discuss the details of each of these points, but you can see that going forward from 1948 onwards, you can see some of the changes that happened. And then into the 1970s and 80s is where all the divergence starts to happen. So some of the dates in Canada that I felt were important to look at, 1947, where the Saskatchewan Hospital Services Plan was introduced by Tommy Douglas. Tommy Douglas is considered essentially the god of medical services, or Medicare, in Canada. And this looked at providing government-funded healthcare insurance. 1956, we had the Hospital and Diagnostic Services Act that led the foundation of the nationwide system of hospital insurance. In 1961, all of the 10 provinces and territories had hospital insurance plans, with the federal government sharing the costs 50-50. As I said, that has actually changed over the years, but this is what happened right at the very beginning. And here's this Saskatchewan doctors' strike in 1962. And just like the one that the Americans had in 1948, there was the same sort of discussion and argument about whether this type of system would succeed or would be appropriate to enact. In 1971, the National Health Insurance System was formed. This provided coverage for hospitalization as well as physician coverage. And then finally, in 1984, the Canada Health Act provided for the Canadian healthcare system as it currently stands. And so this is where I suppose the major part of the divergence happened in terms of the system developing into different types of systems. So we're going to look at a comparative analysis here between the US and Canada. Now, when I was looking for this information, I came upon a very interesting article about why we do these types of comparative analyses. And so I thought this was very interesting to share, because I think this is sort of what we are also trying to do, trying to understand what's happening in the two different systems. We need to gain some perspective. We want to make sense of our own healthcare system by studying others. And we also want to appreciate what is by reference to what it is like or unlike. And so our two countries, because they're so similar, we also want to look at how we provide or administer healthcare. And I think we can help each other look at how we do it and how we could improve. And then, of course, we want to be able to generate causal explanations. We want to be able to understand why something is happening the way it is happening. So we have similar systems and policies, but with different outcomes. So what happens? What is the reason why that happens? And then comparable outcomes, but with a different system and policy configuration. And you can see these 2 points are very interesting because that's something that we're looking at when we look at the two systems. And then, of course, how to draw policy lessons. Transplanting or adapting system features or policy reforms, we want to draw lessons about the system and the policy changes that are promising and doable. And then we want to know what's promising but not doable, and then what's doable but not promising. So if someone wants to read more of this, of course, the reference is there at the bottom And I especially liked the little cartoon there. It's a seminar on how to find someone cool to imitate, or in the other direction, how to find your own unique path in life. So I feel with this background, we're going to dive right into what we're going to talk about. Okay. So this concept of universal healthcare, what does it actually mean? So when someone says we have universal healthcare, what does it mean? We mean that all the people or residents of that country have access to the full range of quality health services if they need, when and where they need them. The Canadians describe this under the Canada Health Act. And this says all Canadian residents have reasonable access to medically necessary hospital and physician services without paying out of pocket. But the US system doesn't really have this sort of universal healthcare. So that's your first difference. Then we look at the healthcare insurance coverage. So the US is very complex, and it was really hard to understand some of the ways people are insured. And then, of course, we looked at groups that were uninsured or underinsured. And again, that's a complex system. It's also a mixed system where you have private health insurance, public health insurance, and so on. In Canada, 100% of Canadians are insured with the National Health Insurance System. However, 2 out of every 3 Canadians also have some private health insurance. And as of 2015, 90% of Canadians get that private coverage through their employers, unions, or some other form of group coverage. Okay, so this was a very interesting slide that I found that actually looked at type of coverage in 2020, and it compared it to change through from 2018 to 2020. So in this, we can actually look at the percentages. So most people, almost 92%, had health insurance. And then there's a small group that are uninsured. And then there are other smaller groups that are, some people have private plans, some have employment-based plans. There's a concept of direct purchase, marketplace, TRICARE, some people with any kind of public plan. And then we, of course, had the Medicare, Medicaid, the VA, and the CHAMP VA. Now, I'm not completely familiar with the CHAMP VA. Perhaps someone can help me with that. So from 2018 to 2020, we have a very stable situation and quite a large group of people. Now, the same sort of data for Canada looks like this. We have 100% public coverage. It is universal automatic coverage through Medicare, funded and administered primarily by the provinces and territories. And I talked about some of the private complementary coverage. So this is about 67%, mostly employment-sponsored groups, policies for vision, dental, prescription drugs, allied professionals, private rooms in hospitals, etc. There is a bill that's currently going through the system, and that bill has to do with diabetes drugs. And if you've ever met me, you'll know I'm very passionate about medications for diabetes. Let's see where that goes. Okay. And then we come to funding for healthcare. Again, the US has a complex mixture here. We have federal, state, local government, we have private insurance, individual payments, and we looked at Medicare, which was financed by payroll taxes, and then Medicaid and Children's Health Insurance Program, which is the CHIP, were financed by the federal and state government. So the Medicare-Medicaid system kind of resembles what happens in Canada in terms of funding. You saw the slide in 1971 when they decided they would share. So 50% coming out of the federal government, and that was directly taxed. So federal taxation, and then 50% through the provincial or territories. At this time, that has sort of changed. That percentage has changed a little bit. So 70% is publicly funded through general tax revenue. So somewhat similar to what happens with Medicare in the US. And then the provinces and territories generate about 78% of the cost. And then the rest of it is paid by the federal government through what we call the Canada Health Transfer. And just like we talked about before, all the 5 pillars of the Canada Health Act must be met or be satisfied before this federal transfer of money, which is called the Canada Health Transfer, would happen. So, and I don't think there's ever any time that that's not satisfied. It's just, it is, however, a principle. So then let's look at the national health expenditure in terms of a comparison. So in the US, as of 2022, a total health spending was 400 and, no, I can't even say this right, 4,664 billion. And compared to that, the Canadians spent 313 billion. And I'll show you a little cartoon about this, which kind of gives us an idea. But remember, we have to divide this by 10. And even if we divided it by 10, you'd still see that there was a difference. Then we looked at the per capita spending, and you can see $12,914 per American compared to $6,450 per Canadian. This is about 17.4% of the GDP, and this is in 2022. And then for Canada, this is 12.2. And this is what I meant when I said, just let's look at that healthcare spending. So the red is all of US, and that little slice, tiny little slice is Canada. But it's disproportionate because we have a smaller population. So in terms of that, we would have to divide those numbers by 10 to really understand if there's a comparison, but it would still be a huge difference. This is a graph that looked at the average annual growth rate in health expenditure per capita from 1980 to 2022. And this actually looked at data comparing the US to some of the countries that we consider similar, or the OECD countries where the healthcare systems are very similar and they're tracked in similar fashion. And we have appropriate data available to create this sort of comparison. And you can see that there is a larger amount of spending with the US systems. And you can see there's a little bit of a decrease here with the US, but this picks up again when you look at data from 2023, 2024, but I couldn't include it in this particular graph. So really, it shows that the spending is kind of gone up, and it has gone up even in comparison to similar groups of countries. This is a graph that looks at the same countries, but if you look at Canada, you can see in this particular time frame, we're looking at the US around the $12,000 mark, and we're looking at Canada just about half of that. And if you look at the average, you can see it's around half that mark. And again, these are the similar type of countries that we look at. And data is from the Organization for Economic Cooperation and Development. Now, if you look at the way the Canadians look at it, they've also got a way of looking at this data. So here's that particular graph. This is from the Canadian Institute of Health Information. They looked at the national health expenditure trends in 2022. And so we look at a similar type of situation, and we're looking at Canadian dollars here, so that's why that looks a little bit different. So you can see around 16, maybe $17,000, the US, and then we can see Canada approximately half. But they're catching up this year in particular, 2024, 2025, we're sort of catching up there, similar to what Germany looks like in this particular set of data. Okay. This is a very interesting graph that looks at health expenditures as percent of GDP from 1970 to 2022. Now, if you look at this particular point right here, where green is the US and blue is the comparative country average, which we will say is about right in terms of the Canadian data, you can see that in 1971, you can see we were quite close in terms of GDP. And then if you get into the 70s and then into the 80s, you can see that divergence start to happen. And then, of course, we have huge amount of diversion here, and you can see where the US is pulling away completely in comparison. So the percent of GDP being spent has gone up, and it appears to be climbing still. And what does this look like for the Canadian system from their point of view? This is again data from the Canadian Institute of Health Information, the CIHI data. And if you look at this is from data from 2020. You can see this is approximately 18.3% here. And we know that there was a peak here somewhere in 2020, and then it kind of fell, as you saw in the other graph. And then you see Canada also pulling closer, just like Germany, almost similar. And then the next graph, also Canadian data that looks at how does Canada's health spending compare? So we look at in terms of public and private sector shares. So we look at Canada, you can see that quite a large percentage here, and then you look at the US and you can see 50, maybe 60%. So, and then of course, look at all the comparator countries as well. And this data looks at what happens with healthcare expenditure and where some of this money is being spent. With the US, it appears that there is much more money being spent on administrative costs compared to what is being spent on caring for long-term or healthcare or long-term spending. So again, this is cost per capita. It looks at, if you look at the top, you can see the administrative costs are $1,001, and then the long-term care costs are $973. If you look at Canada, you can see that Canada is spending less. And if you look at an average of all these different countries that are compared to each other are very similar in terms of GDP, etc., you can see the average here at 213, 219. So it's almost a fifth of what's happening here. However, Canada is spending much larger amounts, even larger than you can see from 1,433, etc. And some of the Europeans are spending, of course, much more. But we're sort of here in the middle with Canada on average. So that is one big difference that we've kind of looked at, which potentially has an impact on what happens with healthcare in the country. Now, where does the money get spent? And how can we understand what's happening? So there was this whole situation where we looked at, okay, where's the money going? And it's wasteful because it's not being used for direct healthcare, and something is wrong. Money is getting spent, but somehow we're losing it somewhere. So this is a little cartoon that looked at where it goes, and they sort of looked at, is this because of administrative complexity? So they realized that was something that was happening. Some of it is inefficient spending, so failure of care delivery. Then you have operational waste or pricing failures or failures of care coordination, etc., low value care in some cases. And some of it, of course, to fraud and abuse. So some of the money is lost in that way. We also know that the wasteful spending or wasteful healthcare spending is part of what we call administrative spending. So that means there's a lot of money going into inefficient systems that potentially may be improved. Okay. Now we could look at the US in terms of outcomes. Now this is once again the same group of countries, the Organization for Economic Cooperation and Development look at that. So this blue is looking at the US, and then of course we can see some of these other countries. So we're not doing so well in terms of life expectancy. Then there's a problem with infant mortality. Unmanaged asthma was used as a point. Unmanaged diabetes. So this is something concerning. And then, of course, safety during childbirth was also considered an issue. And heart attack mortality, once again, not as well as one would hope. Okay. And then this is a set of slides that was compiled by a group. It's called Mirror Mirror, and this is one of their articles. They looked at what is happening with the healthcare system and what are we going to do about it type thing in terms of the US. So, and we're going to look at it in another graph as well, just to sort of understand what's happening here. So once again, the countries are, Australia, Canada, France, Germany, Netherlands, New Zealand. This is the group of OECD countries that are used as comparators, and here's Canada right here. So we have overall ranking. The US stands over here in terms of access to care, and then care process is actually really, really excellent. And I'm going to talk a little bit more about that because it's very exciting that it's come out this way in the data. And then we look at the administrative efficiency, and we looked at the slides where we had wasteful healthcare spending, administrative costs, etc. Then we look at equity. It's problematic. And then, of course, we look at health outcomes. Again, a little bit problematic. Just to look at it in another way. All right, here we go. It kind of gives us a little bit more graphic look at what's happening here. So you can see Canada is not in the top 3 average in terms of healthcare system performance ranking. We're sort of right here, but within this 9-country average group. And then you can see that US is quite far in terms of a point of reference. The next slide is going to look at the healthcare system performance compared to spending. And once again, the US pulls completely away from all of the comparator countries. And you can see Canada right there, right in the middle. Similar, very similar to Sweden, to Germany, Switzerland, France, and New Zealand. You can see the US on this axis, healthcare spending as a percent of GDP, which we looked at. And then we looked at healthcare system performances in comparison. And the next slide is looking at the US among the top performers for care delivery process. So this one is really very interesting and completely understandable. So the US is far and away one of the best providers in terms of care delivery process, which means that once you get into the system and once you are able to get the healthcare, then it is absolutely fantastic, absolutely phenomenal. So as an example, if a baby is born prematurely, if they're born in the US, chances are they're going to survive. Much better outcomes are expected or do happen. We know statistically and we know from experience that that does happen. And that is completely evident in our data analysis. And you can see some of the countries don't really do as well. Canada, you can see within that, just below the top three average. So the Canadian healthcare system, in terms of process, is quite comparable. I do have to say, however, some of the problems here can lead to people escaping to the south to get some of the healthcare that they want. So, for example, the premier of Newfoundland had a valve stenosis, and there was such a long wait time, he decided to fly in his private jet, go to Miami, and get his valve fixed. But the thing is, he could do that, and not everyone can do it. And of course, he had fantastic outcome. So that's something interesting that I've found. And then the US physicians and patients are most likely to face hurdles related to insurance rules, billing disputes, and reporting requirements. And I think that is, again, something that we can understand given the complexity of the system and all of the different types of access people have or don't have, and all of the factors that impact care. You can see Canada very similar to some of the other countries like the Netherlands and Sweden and Germany. So, of course, you can see the best case scenario is with the UK, which is a publicly funded or universal healthcare system, somewhat similar to the Canadian healthcare system. And so you can see that it's a high performance system with much less of some of these disputes that we typically see in the US. Certainly in Canada as well, we do see some of this. The US and New Zealand were behind their peers for equity in healthcare access and experience. So this was an unusual finding, because typically you'll find that New Zealand is usually within the top 8 or 9 average. But this time, in this particular point, it did trail behind its peers. And Canada right there in the middle. So there are issues, of course, with access, but they're not as severe as perhaps New Zealand or US. And this, again, is data which looked at length of life, and Americans perhaps live shortest lives and have the most avoidable deaths. You can see the highest performing countries over there, Canada right here, somewhere in the middle, and then the US with issues in terms of avoidable deaths as well as longevity. And then, so we've looked at what's happening with the US system. Now, what's happening with the Canadian system? Well, first we talked about, is this truly universal? Is this truly a single payer system? Is this truly, is this insurance truly all 100%? well, you could see that some of those things, there are nuances to all of that. And so you can run into problems. Some of the issues we have, which are truly problematic, include things like access to angioplasty, cardiac cath, intensive care units, and then the wait list. Of course, you've heard of wait lists. You could literally wait a year, maybe even longer for an MRI. And this is much more pertinent if you look at what's happening in the elderly or geriatric population. So if there's a wait time for a hip or a knee replacement, then of course that wait time becomes much more significant. I mean, imagine someone who's 75 compared to someone who's 55, and you have to wait a year. What does that mean? For cataracts, of course, that's also problematic, cardiovascular surgery. Now, wait times for treatment were about 13.3 weeks. And so this was considered at least 2 or 3 times longer than what should be expected. And of course, for diagnostic tests, wait times are much, much longer. So these are some of the very serious problems with the Canadian system. And I gave you an example of what happens sometimes when people have the ability to simply fly south and have treatment done. And other people have done this as well, not just people who are very well connected. I have a colleague diagnosed with breast cancer, and there was a delay, not in the diagnostics, but in the actual surgery. So she decided she would go to the Mayo Clinic, and her surgery happened within days. So we do have these very, very truly appalling wait times sometimes. What are some of the lessons? The first lesson is when the government provides a product free to consumers, inevitably the demand escalates and spending increases. So because people perceive everything as free, because products are being provided at zero price, they're treated as if they actually have a zero resource cost. But that's not really the truth. And so lesson 2, everything does have a cost and someone has to pay. So part of the reason why we have all these wait times or some of these other issues is because that's the way it's being managed. And it's based on what the system requires us to do. So the healthcare system requires at times, because it's considered to be free, it's something that the cost will escalate. Now, where does this cost go? It usually goes to the government. And if the provincial governments can't handle that kind of cost, well, then it goes to the federal government. For example, we had recently problems with mental health care, and it became a big crisis, and everyone thought, well, something needs to happen. Well, something did happen. The federal government came in and rescued the provincial governments, and a lot of money has been spent on mental health care. What the outcomes of that are going to be, we'll just have to see what happens over the years, whether that spending was effective or efficient. We don't know yet, but it did happen. And these are some of the sources of information that I used. But I want to point something very interesting out. There is something called the Commonwealth Fund. This is a US foundation set up in 1918, and the purpose was to improve healthcare for all Americans by a lady by the name of Anna Harkness, and she gifted $10 million to the cause. This particular foundation is still functioning, and I've used many of the reports, read through many of their reports, looked at their advice and so on. And as I mentioned, I looked at the report. It's called one of the 7 reports that are called Mirror reports. They look at what is actually happening to the US system and what needs to happen to change. And yeah, so that was something very interesting that I found. And that's all I have to say. This was yesterday from my window. It was really cold. So I would appreciate comments, any questions.
So I'll read from the chat. Thank you so much. That was a great comprehensive presentation. Dr. Lee asked, in Canada, are there private hospitals and concierge type doctors because of the delays in care? And she mentioned,
No,
so South Korea has a socialized model, but has massive privatization, which leads to inequity in care. Do you have that, private hospitals, ways for people to kind of get around the public system?
we do not. However, Quebec has a slightly different system, and some of the things can be accessed through that system, but it's not very extensive. But no, we do not have that concierge or private system. No.
Yes. Actually, I'm not a doctor. Although I always say my degree has a D in it, but the first letter is a J. I'm a retired member of the New York State Assembly and the author of New York State's single-payer health bill. I have two questions which may be related. One is on the wait times in Canada. I don't know if there are comparable wait times in the other countries that were looked at, but why are there wait times in Canada? In the US, we have publicly funded insurance for most of the people who need hip replacement. It's called Medicare. But, we don't have wait times for hip replacement. Why in Canada? And you said that when people think something is free, they use it a whole lot more. Is there evidence of greatly increased utilization in Canada? And if so, is there indication that that's inappropriate utilization? I mean, are Canadians going to the doctor because it's something to do on a weekday afternoon?
We hope not, but yes,
Right.
thank you so much. Thank you. Thank you for the questions. The first one has to do with wait times. So I didn't put all of this detail into the whole structure of the way this presentation is, but for example, looking at the number of CT scanners or MRIs. Okay, so the system can only have a certain number of machines or equipment. And so without actually buying more equipment, how do you get everyone looked at quickly? You can't. And that's part of why the wait list happens. And the same is potentially true with having access to, for example, specialist care. So with Canada, as with the US, we are having a crisis of primary healthcare. Most of the people who are now graduating from primary, so for primary care practitioners or family doctors or general practitioners, most of the graduates simply do not want to practice the traditional way of doing medicine, so family medicine. So as a consequence, people don't know where to go. So then that's where the inappropriate use of different services comes into play. So for example, you can go into the emergency department and you realize many people are just there because they simply have no access to a family doctor. So all they needed was maybe they needed their diabetes medications renewed. So where should they go? So they're going to the emergency department, clogging up that system. Or there are other minor problems that are causing those sorts of problems. So there's almost a fifth of the population that does not have access to family doctors. And as the older generation retires, we're seeing more and more the difference in the human resource. The individuals that are now choosing to practice family medicine, first of all, they're fewer. And secondly, they don't want to practice the way that traditional family medicine grads would practice, or family physicians would practice. People just want to do shift work, for example. They want to go to the emergency, do shift work, or I've met people who want to partially practice in the territories. So this way, they don't have offices in St. John's, for example, that are fully functional, but they go to Iqaluit and they work over there for 2 or 3 days. So what happens is you have inadequate coverage in the city where they're supposed to be living, and we have inadequate coverage in the territories. So it's sort of like a culture shift that has happened.
Is any of that related to your public health coverage system? The shortage of machines and people not wanting to go into primary care?
Equipment shortage, of course, is obviously related with money. So how much money? How much money should there be? How much should be spent, etc. So there's always a cap on that. So that's related. But why people are not choosing to go into, say, the traditional family practice model of care, because we're slightly different. So internal medicine is not considered primary care in Canada.
Right.
So that is a slightly different. Internal medicine is considered a specialty or a subspecialty, and
Used to be that way. Used to be that way in the United States too, by the way.
Okay.
That's changed. Yeah. Yeah.
Okay, that changed. Yeah, I wasn't
changed.
aware. Thank you.
Yeah.
No, so internal medicine is considered subspecialty or specialist, right? So
Yeah.
we don't do primary care. So that big section of people is sort of not caring for patients in that way. I do feel that it's a cultural shift. I feel the people that are coming into medicine now, they're just very different from what was happening before. For example, instead of doing the 24-hour call, people want to do either a 16-hour or 12-hour call. And this is what's happening to our residency system. Okay, we have double the number of residents, but we cannot cover our call shifts. And that same culture has basically transferred into our work culture. So now we have family doctors who just have probably never done a 24-hour shift. So we can't expect them to do that now.
Well, that's partly what's going on in the States as well, the sort of quality of life issues, especially for trainees. But we also have and I don't know if this is true in Canada, in the States, there's a huge difference in the earning capacity of a primary care doc versus a specialist, especially a specialist who has a procedure. Because, the bias is in our system is you pay doctors for doing things, not for thinking.
Yeah, exactly.
So,
and that's
a lot
exactly
of subspecialize for that reason.
Yeah, totally. And that's very much true here as well.
Is that true there too? Yeah.
Very much true. The primary care physicians are really not being compensated for the amount of work that they do. With the COVID system and virtual care, some things did get better. So for example, all the phone calls that people would make, sitting down and looking at blood work or saying, okay, this medication, that medication, this little thing that had to happen. Now that does get compensated, but again, initially it was reasonable and people felt, okay, let's do some of these virtual clinics and so on. But now some of the rules are changing, and again, they're not compensated fairly. So there is certainly that situation that unless you're procedural and you're fee for service, you're just not going to be the same as a specialist. So most of the people are disincentivized to go into some of these specialties where you sit down and you actually talk to people. So yes, that is very much a similarity.
Well, and part of it is that because of the push to put 10 pounds of poop in a 5-pound bag, those primary care docs, they don't have the time to talk to people. It's a very
It is.
frustrating way to practice medicine if you can't really spend the time that you think you ought to with your patients. It's all, move the meat. It's like factory.
Yeah,
So
absolutely.
that's another disincentive.
Yeah, absolutely. I mean, I can tell you that I work at Memorial University, so there's a student health center. And you know what they have for a little plaque just outside for the students?
Mm.
10 minutes per appointment, one problem only.
Only, yeah. Yeah,
So can you imagine, how does a doctor handle that? Like, and how do you do like 10-minute one problem? Like, how do you do it? If you have a second problem, you need to rebook and then come back, and it's not sensible.
and what if the problems are related? I mean,
Yeah,
like,
right.
hello.
Okay. Yeah. I'm just gonna kick you out. 10 minutes up, man, you're out.
Yeah,
You
no,
rebook
it's
with.
true.
It's just ridiculous. It's just this kind of commodification of
Yeah.
it's kind of a it's kind of an unreasonable commodification, right?
Yeah.
How do you do that? But
It's
then
it
when you look at, okay, they have an office, they have employees, they have overheads. So
mm,
what they need to do, they have to see 100 people every single
make
day
yeah,
to afford to stay open.
yeah,
When you talk to them about, okay, guys, what are you doing? What is this 10-minute business? What are you even
yeah,
doing? They're like, we'll just shut down. Okay, goodbye. I'm out.
yeah. Well, a lot are
What do you-
leaving anyway, just because it's not good medicine. It's a very, it's very frustrating and creates a lot of stress when you can't really do what you think you need to do.
Exactly.
You know.
And then
But
you
of
don't
course,
even
you're
provide the
responsible for
healthcare.
everything.
Yeah, totally, totally.
So I think we're running low on time. There was just one other, there were a number of really fantastic questions in here. One person specifically asked, why do so many Canadians need private health insurance? Why, if you have this single payer system that covers everything, why does almost more than half the people have the private?
Employee, yeah.
Yeah.
That's an excellent question. And the answer is that some of the services that are not covered, so for example, eye care and dental care. Now, dental care has become part of the national healthcare insurance for the elderly, but not for the younger people. So you need dental care, you need eye care, and of course, medication. Now, everybody wants Ozempic. Who's going to cover that, right? So drug coverage is primarily what drives the private insurances. So that's why they need it. So the government, for example, what are some of the medications the government will cover? There's very basic ones, and they're only covered for groups that are considered under a certain financial constraint, right? So if you have a certain amount of, maybe $20,000 a year, or if you're a certain age group, or if you have certain types of illnesses, your medication may be covered. But again, those medications will not be top of the line, right? I can prescribe Monjero. It doesn't mean they're going to get it, right? So that's why the insurances exist, those private insurances that happen through employment, or through unions, or through some of the different other things.
A lot of our insurers don't cover those drugs either without you going through prior authorization and enormous hoops before you can get there. It's very penny wise and pound foolish when you look at the overall health of a patient and how much you have to spend on the patient. Yeah. They'd rather wait till you have your heart attack, then they'll worry about,
Yeah.
treating your obesity or whatever.
Whatever, exactly. I mean, this is so hilarious. But yes, every day I fill prior authorization, which we call special authorization forms. This is the bane of our existence. Every day we have to sit down and fill this. This person had a heart attack, so you can give them an SGLT2 inhibitor. Well, this one has had a stroke as well as a heart attack. Why don't we just give them a tiny amount of Ozempic, like only 1 milligram, not the amount that they actually need, right? And most of the time they'll say, okay, no. But that's a kind of a different sort of fight. But also in terms of guidelines, look at the guidelines. They're also upside down. We need to treat something else, and instead we're doing something else. So Yes, money is really very much the bane of our existence right now, and all these prior authorizations, special authorizations. I think they're designed to really addle the doctors' minds, so they stop filling them and stop sending them back, and the poor patients are just stood there waiting to see if something will happen, and it doesn't. So yeah, it's very much similar, very much similar.
That was a very interesting talk, Doctor. Thank you so much again for being with us tonight and sharing your study and your time with us. If would you be okay to share your contact information in case somebody else would like to ask some questions, if they're still interested to engage with you offline? That will be probably very informative for them. It looks like everyone enjoyed your topic. It's very engaging topic, and I wish we had more time. But we are only allowed a certain amount of minutes for the meeting. I'm so sorry. But again, if you can share your information, that would be great.
Yes, so my email is in the chat box, and if somebody wants to WhatsApp, that's no problem. Loretta has my number. Dr. Morrison has my number. So yeah, no problem. Yes, absolutely. But you can see, it's very interesting. We're similar, but we're different.
Yeah.
Yeah.
Similar problem. By the way, I did put in the chat, I did give you some information about VA Champus.
Yes, I read
and TRICARE. All
that
right,
thing.
good.
Yeah, I was looking at that insurance. Yes.
Yeah, just
Yeah,
so you
again, it's very complex.
Oh,
The
yes.
claiming system relatively easy in terms of, it's not gonna be this complex.
No.
But yeah. Oh, you want my slides? Yeah, absolutely. Loretta, you have my slides. So if someone wants to look at them, absolutely. And if you have any other questions,
Yes,
absolutely.
I have the slides. Reach
Yeah.
out to me. Happy to
Yeah.
share. And
Yeah.
also, we are recording. So as soon as we get it prepared, we will put it up on our website for anyone who may have missed it. We'll also announce that in our next newsletter that it is available.
Thank you.
Thank you.
All right. I think that
Thank
wraps up
you.
for tonight. Thank you so much, everyone. Have a great evening.